Hey everyone! Today we're jumping into a really fascinating diagnosis, one that can feel like a real clinical puzzle, especially when you encounter it on the wards. We're talking about lymphocytic hypophysitis, a condition you absolutely need to have on your radar, particularly when you're dealing with a patient in the postpartum period. So here's how we're going to break it down. We'll start with a classic patient case, then do a quick anatomy refresh. After that, we'll walk through the diagnosis step by step, explain what the disease actually is, cover the treatment plan, and finish up with some super high-yield pearls you can take to your next shift. Let's get right into it. All right, let's set the stage. Like any good medical detective story, this one starts with a patient and a really challenging set of symptoms. So picture this. A new mom walks into your clinic. She's a few weeks postpartum and she just feels awful. We're talking a crushing headache, a kind of fatigue that's way beyond just being tired from a new baby, and she's constantly nauseous. Now, the trap here is to just write this off as normal postpartum stuff, right? But that's a huge potential pitfall. And that leads us to the big question you have to ask yourself. Is this just the baby blues and exhaustion, or could these symptoms be a sign of something much more serious? Something happening deep inside the brain in that tiny little pocket of bone called the sella turcica, where the pituitary gland lives. To even start to answer that, we've got to know the anatomy. See, the pituitary gland's location is everything. It's all about location, location, location when it comes to the symptoms it can cause. So let's pull up our anatomical roadmap. Okay, let's get our bearings with this MRI. You can see the pituitary gland right there with the open arrow tucked into the sella turcica. But look at its neighbors. Right on top of it is the optic chiasm. That close proximity is exactly why an enlarged pituitary can cause vision problems. And see that thin stalk? That's the vital connection to the hypothalamus. So a problem right here can cause this perfect storm of both hormonal and neurologic symptoms. Okay, so with that anatomical map fresh in our minds, let's get back to our patient and start following the clues that are going to help us crack this case wide open. So the workup is pretty logical. You start with some basic labs, you see what they show you, and those results are going to point you toward ordering the right imaging study. And that's where we'll find the key piece of evidence. And boom, here's our first major clue from the blood work. You draw an 8 a.m. cortisol, and it comes back critically low, less than 3. This isn't just a little off. This is a massive red flag. A number that low screams adrenal insufficiency, and that gives us a really powerful reason for why our patient is so tired and nauseous. That scary cortisol level is what gets you the MRI, and what we find here is absolutely pivotal. We're not seeing a typical, well-defined tumor. Instead, the MRI shows this diffuse, enhancing mass with a really thick pituitary stalk. That thickened stalk is the key imaging clue that should make you think, this looks more like an inflammatory process, not your garden variety adenoma. And all of those clues lead us right here to our diagnosis, lymphocytic hypophysitis. So what is it? Well, it's basically an autoimmune attack on the pituitary gland. The body's own immune system gets confused and starts inflaming the gland. This inflammation makes it swell up, causing the headache. While at the same time, it's destroying the cells that make hormones, which explains that low cortisol we saw. So now that we've put a name to it, let's dig into the why and the who. What actually causes this, and who's most likely to get it? The classic patient, just like in our case, is a woman in late pregnancy or in the first few months after giving birth. But, and this is really important, there's another major cause that's becoming way more common. Checkpoint inhibitors, the immunotherapy drugs used to treat cancer. These drugs rev up the immune system to fight cancer, but sometimes they can cause collateral damage, leading to an autoimmune attack on glands like the pituitary. Now, this inflammation can mess with pretty much any hormone the pituitary makes. The number one target is usually ACTH, which leads to that cortisol deficiency. But it can also hit TSH, causing secondary hypothyroidism or the gonadotrophins. A little less often, it can even affect ADH, leading to diabetes insipidus. And I really want to hammer this point home. Out of all those possible deficiencies, the loss of ACTH is by far the most common and the most dangerous. If you miss secondary adrenal insufficiency, your patient could go into an adrenal crisis, which is a straight-up medical emergency. This is exactly why we can't just brush off symptoms like severe fatigue and nausea. Okay, so we've got the diagnosis, we know why it's so serious. Now, what do we do about it? The whole goal here is to restore the body's balance. We're basically tackling this on two fronts. First, and most urgently, we have to replace the hormones that are missing. This is non-negotiable for the patient's survival and just feeling human again. And second, we want to calm down that inflammation in the pituitary, to shrink the mass, relieve the headache, and maybe even let the gland heal a bit. So, job number one is replacing that missing cortisol. We start them on hydrocortisone, usually about 15 to 20 milligrams a day, and we split that dose to try and mimic the body's natural rhythm. Now, the really cool thing here is that glucocorticoids do double duty. They replace the missing hormone, and they're powerful anti-inflammatories, so they help shrink that swollen gland. It's like two birds with one stone. All right, let's wrap this up by boiling it all down into a few super high-yield clinical pearls. This is the stuff you absolutely need to remember when you're on the wards. Pearl number one, context is king. If you have a patient who is late in her pregnancy or has just had a baby, and she comes in with a new, nasty headache, vision changes, or that crushing fatigue, lymphocytic hypophysitis has to be on your list of possibilities. Pearl number two is all about the imaging. When you look at that pituitary MRI, don't just hunt for a round tumor. A thickened, brightly enhancing pituitary stalk is a huge red flag for an inflammatory process. It's that one finding that should really push you away from thinking adenoma and towards thinking about things like hypophysitis. And finally, a super practical management pearl. If your patient also needs thyroid hormone replacement because of TSH deficiency, please remember, you cannot use their TSH level to see if the dose is right. It's useless. The factory that makes TSH is broken, so the number doesn't mean anything. You have to follow the free T4 level and aim for the mid to upper end of the normal range. And that leaves us with one last thing to think about. For years, this was taught as a rare disease of pregnancy. But now, with immune checkpoint inhibitors being used for more and more cancers, are we watching this disease change right before our eyes? Could the drug-induced iatrogenic form become the new, more common face of hypophysitis? It's a really critical trend for all of us to keep an eye on. Thanks for joining me for this one.